You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for June 14th, 2019. This week, vitamin D, ICDs in patients with end-stage renal disease, aspirin again, type 2 diabetes remissions, and paclitaxel. Let's start with vitamin D. The American Diabetes Meeting in San Francisco saw another vitamin D failure. Supplemental vitamin D given to 60-year-old people at high risk for getting diabetes did not prevent new cases of diabetes. Importantly, these patients did not have low vitamin D levels. I highlight this study because it brings to mind one of the most relevant editorials of modern time. In 1994, the late Professor Doug Altman wrote in the BMJ, "The Scandal of Poor Medical Research." His first line was great. He said, "We need less research, better research, and research done for the right reasons." Now, I don't mean to imply the vitamin D paper is fraudulent or misleading. It is not. I mean to say that it is wasteful. First of all, the median BMI of participants in this study was 32. Does anyone really think that giving a vitamin to obese people who are not deficient in that vitamin will be useful? If we want to prevent type 2 diabetes in obese people, perhaps addressing the reason they are obese would be the best idea. And more on that in another story in this podcast. Second, is there an RCT, not observational study, RCT of vitamin D that has ever shown benefit in people who don't have low vitamin D levels? I don't know of any. Third, this study enrolled almost 2,500 people followed for 2.5 years. That cost a lot, perhaps millions of dollars. Then it takes up space in New England. Think of the opportunity cost. What could those millions have been spent on? What other worthy studies could have been published in the New England Journal of Medicine? Vitamin D comes from going outside in the sun. The solution to reducing diabetes, therefore, is the same as reducing heart disease. More parks, less pills. Distraction remains one of the greatest foes for helping our patients attain health, and vitamin pills are a major distraction. Second topic are ICDs in patients who have end-stage renal disease. When it comes to doing bold research, Dutch investigators from Leiden University impress me. The ICD-2 trial asked the question of whether an ICD can reduce sudden death in patients on dialysis. Circulation published this important study, and good on them. There were just under 100 patients per group. It was simple: ICD versus no ICD, primary endpoint sudden death, all-cause death, and ICD complications were the secondary endpoints, and the results were clear. No difference. They even stopped the trial after 188 of the 200 patients were enrolled because of futility. All-cause death also was not significantly different. And get this, despite the fact that all of the ICDs were implanted in one academic high-volume center, 1 in 4 patients who received an ICD had a device complication. Now, I wrote a column on this study that is coming out soon. I hope you read the column and leave some comments, even if you disagree with me. The first point to make about this study is that many critics pointed to the author's choice to include only patients with an EF greater than 35%. That's right, greater than 35%. Not only do I reject this criticism, I think this choice improves the trial's external validity or generalizability. Why? The first point to make is that patients on dialysis have a high rate of sudden death, due often to bradycardia. The rate of sudden cardiac death in dialysis patients is actually higher than those in heart failure. Second point, and this is critical, the benefit of the ICD takes up to 2 years to accrue. In the landmark trials done decades ago that compared ICD to medical therapy, Kaplan-Meier curves took 1 to 2 years to separate. Thus, you can't enroll patients on dialysis who have a low EF because they don't live long enough to benefit from the ICD. Indeed, patients with a low EF account for only 10 to 15% of dialysis patients. I expand on that point in my written column. The bottom line is this: if you want to help patients with advanced kidney disease, Keep them away from the EP device lab. Full stop. Third topic, aspirin. Again, I'll keep this brief because I've discussed aspirin for primary prevention before. But the Journal of American College of Cardiology has published a massive meta-analysis of 15 trials of primary prevention aspirin. This included 165,000 patients. In brief, when aspirin was given for primary prevention reasons, it did not improve overall death, CV mortality, or fatal MI. There were small relative risk reductions of non-fatal MI and TIA, but these were balanced by an increase in major bleeding and intracranial bleeding. I went and looked at the table and I did some arithmetic. In absolute terms, the absolute risk reduction in non-fatal MI was a mere 0.3%. Aspirin also had no effect on cancer-related deaths. So this massive meta-analysis does not change my view, and that is that we should advise people with heart disease not to take aspirin. There is no net benefit. Now, one line of thinking is that we might reserve primary prevention aspirin for our higher risk patients, but I disagree. I find no compelling evidence for aspirin unless there is established heart disease. And I get this idea from looking at the main forest plots from the meta-analysis. This shows that the studies driving the reductions in non-fatal events in this big meta-analysis were mostly from decades ago. The newer trials like ARRIVE, ASCEND, and ESPRIT showed no significant reduction in CV events. And that evidence should come with an expiration date is a really important point. Over time, the rate of cardiac events is going down. This is due to both temporal trends, stuff like less public smoking and removal of trans fats from the food supply, and it's also due to better baseline medical therapy. This is important because it's harder for any primary prevention intervention now to make a difference. Meta-analyses that combine very old data with new data are flawed, and I'd urge you to keep an eye out for meta-analyses that do that. I also agree with the point made by Dr. Brian Silver from UMass. He asked about data on disability from events. For instance, the amount of disability from an intracranial hemorrhage is going to be a lot more than from a non-fatal MI, especially in this era of higher sensitivity troponin testing, because now the diagnosis of MI is much easier to make. So keep spreading the word. Aspirin is good if you have blood vessel disease or prior cardiac events, but otherwise, get people to stop this drug. Like vitamin D, aspirin for primary prevention is a distraction. The next topic today concerns type 2 diabetes. The title of the story caught my eye. Here it is. Quote, "Type 2 diabetes message has got to be trashed." This from the senior author of the DIRECT study. Wow, was this ever a discovery for me? As an AF doctor in one of the U.S.'s most unhealthy states, I see a lot of people with type 2 diabetes. Now, I always discuss weight loss because I think weight loss is the best AFib antiarrhythmic drug. And as an aside, I mentioned that blood pressure and glucose levels will also improve with weight loss. But what I did not know was that if you tried hard enough and got your patients to commit, a big percentage of them can put their diabetes into remission. Let me repeat, diabetes into remission. This was the message that Dr. Professor Roy Taylor from Newcastle University presented at the ADA meeting. Here's the scoop. The DIRECT study is a cluster randomized trial that was done in 49 primary care practices in the UK. Practices were randomly assigned to provide either a weight management program, which is the intervention, or best practice care by guidelines. These were adult individuals 20 to 65 years old who had been diagnosed with type 2 diabetes within the last 6 years. They had a BMI of 27 to 45, and they were not yet receiving insulin. The intervention, the weight loss management program, comprised withdrawal of anti-diabetic and antihypertensive meds, a total diet replacement of 825 to 853 calories per day, a formula diet for 3 to 5 months, stepped food reintroduction, and a structured support for long-term weight loss maintenance. The authors chose co-primary endpoints with weight loss of 15 kilograms or more and remission of diabetes, and they defined remission as hemoglobin A1C of less than 6.5 after at least 2 months off all anti-diabetic medications. The study included about 150 patients per group. Now, Lancet published their main 12-month findings last March. They found that almost half of participants achieved remission to a non-diabetic state off drugs. And they concluded that remission of type 2 diabetes is indeed a practical target for primary care. In March of this year, Lancet Diabetes published the 2-year results of the DIRECT program, and they showed that sustained diabetes remission at 24 months was found in more than a third of people with type 2 diabetes. And they did a post hoc analysis of the whole population and found that those participants who maintained at least 10 kilograms of weight loss had 64% diabetes remission. Therefore, sustained remission of diabetes was linked to the extent of sustained weight loss. The program used here differs from many weight management treatments. It has a 3-phase integrated structure focusing from the outset on the need for long-term maintenance of weight loss. This included a formal rescue plan if weight gain occurred, and that was a key component because almost half of the intervention group required this additional intervention. Now, this program reminds me of the work of Prash Sanders and Adelaide. Their structured weight loss program also included frequent human-to-human interactions. The take-home, therefore, is this: the message that type 2 diabetes is a progressive condition that will eventually require insulin is wrong. Instead, there is a possible way back, even after diabetes has been diagnosed, and this is surely huge news. Now, of course, I know everyone says the same thing: weight loss is hard, meal replacements aren't sustainable. But here again, it's like the Adelaide work in AFib. This can be done. The first step, I believe, is to convince doctors and clinicians that diabetes, like AFib, can be vanquished. If we truly believe, many of our patients will too. Now pause for a second and imagine the global impact if only a fraction of the millions of patients with type 2 diabetes heed this message. Final topic today concerns paclitaxel and PAD, or peripheral artery disease. While at the EuroPCR meeting, Tricia Ward, an executive editor at the Heart.org Medscape Cardiology, spoke to a number of experts about the paclitaxel controversy. She then wrote a review that is worth your time. Take a look. This all started when Greek authors published a study-level meta-analysis in December 2018 that suggested an increased risk of death late after the use of paclitaxel-coated devices in patients with peripheral artery disease. Then, FDA followed up and they found an approximate 50% increased risk for mortality in persons treated with paclitaxel-coated devices versus those treated with control devices. They then issued a formal warning. Quote, alternative treatment options should generally be used for most patients while we continue to further evaluate. But at the EuroPCR meeting, the initial Greek meta-analysis came under criticism. The first point made was that it was a study-level analysis that did not account for paclitaxel exposure in the control arms, and that more than 80% of patients were lost to follow-up at 4 to 5 years when the mortality signal was seen. Second, other meta-analyses, including patient-level studies, have not replicated the finding. Third, no expert at the meeting could think of a plausible mechanism. For instance, the dose used in the devices is much smaller than that used in cancer therapy, and also, none of the studies has shown a signal of more amputations or critical limb ischemia. Finally, the Greek meta-analysis also lumped in coated balloons and stents, and that's kind of important because these would lead to different paclitaxel handling in the body. So it looks like the mortality signal is spurious, right? No, here's the problem. When the device makers went back to look at their data, they found errors. The Zilver PTX randomized trial published a correction and now shows significantly higher all-cause mortality with the paclitaxel stent. And Medtronic announced that it had omitted some mortality data from safety outcomes tables for its paclitaxel-coated balloon. So one possible solution that Tricia Ward wrote about was the possibility of using limus-based devices. The problem there is not a trivial issue getting an effective sirolimus balloon. That's why hardly anybody has managed it yet. In the closing paragraphs of her piece, we learned that the FDA will review a patient-level pooled analysis coming up soon, June 19th and 20th. And the two large RCTs of paclitaxel-coated devices, two trials called SweetPad and Basal, that were initially halted because of the controversy, they're going to resume. So I'm not a peripheral artery disease expert, but I hope you can see the obvious message in this story. The medical conservative adopts new therapies when the benefit is clear and the evidence strong and unbiased. Gosh, we need better evidence before doing aggressive stuff to people. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, tell a friend, write a review, give us a 5-star rating. This way other people can find us. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org on Medscape.